Okay, so, all right, I'll project. Just very briefly, because we're starting a little bit late, and I really want to give the microphone to Dr. Vose. This is Dr. Alicia Vose. She is a faculty member in the Department of Neurology. We're very honored to have her present today, as I overheard. It's been a whirlwind of conferences and data collection that we're suspecting to be some of the first to see it. We're very excited to get into that. Dr. Vose did a lot of her early training at the University of Connecticut, then George Washington University. Eventually moved over here, did a postdoctoral fellowship with Dr. Gordon, Dr. Fox, and is now very proficient, both clinically, research-wise, and in the space of how injury affects swallowing, cough, and related disorders. So NIH funded, CTSI funded, very excited to have her here. Please take the microphone, and thank you very much.
Great. Is my audio good? All right, this might be the most hot off the press. Wow, that light is really something. This might be the most hot off the press data I've ever presented. We literally finished collecting data on a participant this morning, and I was putting the graphs together in the parking garage before walking in today. So this is really exciting for me to talk about some of the work that we've been doing over the past couple of years. So the title of my slide is Acute Intermittent Hypoxia to Improve Swallowing Function in Chronic Traumatic Brain Injury. And I realized as I have been going through these data and really explaining some of the significance of this work, I have a semantic problem that I'm going to clear up. Because to say that we're looking at swallowing function is a little bit of a misnomer. So I want to rebrand the talk today and say, we're going to talk more about airway protection. And that difference in how we talk about swallowing and airway protection is actually going to be really important to understand why this work matters in the first place. So just to give you a quick roadmap, I'm going to tell you what this talk is going to be and what it's not going to be. I'm going to give you a whirlwind tour of some of the work that we've been doing. I'm not going to go into the weeds on data. If you don't know anything about swallowing, this is your first talk hearing about swallowing, it's a good place to be. I'm going to walk through why we study it, what's the impact, why are we studying it in these populations. So I'm going to start out with a little background. I want to challenge what you think you might know about swallowing, and maybe have you have a different lens on what we're looking at when we study swallowing. In terms of significance, I want to talk about why my lab studies swallowing, why we think this is so important, particularly airway protection, specifically in chronic neurologic injuries like traumatic brain injury and spinal cord injury. I will walk through some data. I want to just tell you a little bit about what we've learned about laryngeal function and airway protection in spinal cord injury and traumatic brain injury. I'll give you a little bit of data. It's pretty preliminary on our use of intermittent hypoxia to improve these functions. And then we're just going to wrap up and talk about where do we go from here? What are the lessons that we've learned along the way? What are our future studies? And just hopefully have a discussion about some big ideas moving forward. So let's get off the bat here. So when I talk about working with patients in terms of swallowing that in traumatic brain injury and spinal cord injury, the first thing that I hear from people, community dwelling adults, otherwise healthy patients, they don't have swallowing problems. Patients that have traumatic brain injury, spinal cord injury, patients have stroke, they have swallowing problems. Head and neck cancer, they have swallowing problems. But spinal cord injury and TBI, they don't have swallowing problems. And you're right, but you're also kind of wrong. And this is where we have to have a little semantic clear up here. So let's think about why do we swallow? What's the purpose? It's pretty basic if you think about it. We're moving food and liquid to our stomach, right? And the purpose of that is to maintain adequate nutrition and hydration. So when swallowing is impaired, we have a term for it, we call it dysphagia. It just means swallowing impairment. So when we think of dysphagia, these are the three diseases that probably for most of you come to mind first. If you work with patients with neurologic injuries, if you're a clinician, these are the heavy hitters. These are the populations. They have severe swallowing problems. They have dysphagia, stroke, ALS, head and neck cancer. This is a video here of what you might imagine looks like, what a swallow looks like with somebody who has dysphagia. So we talk about the purpose of swallowing, right, is to eat and drink to get nutrition. This is an individual, just to orient you. Here's the airway. And this black stuff here is just barium coated, like a paste, kind of a pudding. And this person is having a tremendous amount of difficulty getting this food into the esophagus. A little bit got through there, but they're swallowing 9 to 10 times just to get little piecemeal pieces into the stomach. When I think of dysphagia and when I practice, this is what I'm envisioning. These are patients that can't eat or drink. They often need PEG tubes. They PEG tube for supplemental nutrition because they're just not meeting those needs because of their injury that affects their upper airway and their problems with swallowing. So what does this look like? So I showed you the video before, this is just a little bit bigger. So in dysphagia, what do the patients say? And I'm talking typical patients, stroke, head and neck cancer, ALS. Food gets stuck in my throat when I eat. I feel like I'm choking when I eat. I'm losing weight. It takes too long to eat. I don't feel like I can get food down. These are the patient complaints that we hear all the time. And this is really important because when we're diagnosing patients that have swallowing problems, we really rely on the patient report. Why is that? Because you can't see it, right? We need X-ray to be able to see the problems that are happening with swallowing. So, if you're a physical therapist and you're working with somebody that has a gait impairment, you can watch them walk and you can tell that something might be off, right? With the swallowing problem, we can't really see it. So oftentimes we don't know there's a problem unless somebody is telling us that they have a problem. Or if it's in a population that we typically would anticipate somebody to have a swallowing problem, a brainstem stroke. Someone has a brainstem stroke, problems with swallowing and upper airway are going to be in your mind. That's where the cranial nerves originate in those areas for swallowing. So why am I telling you all of this? Because we rely on the patient report, a lot of patients can get missed if they don't feel like they have a problem. Because the focus is so much on nutrition and hydration, which is the purpose of eating, like I said, the purpose of swallowing isn't to protect the airway. Protecting the airway is a necessary component to make sure that food and liquid gets into the stomach. It's not very helpful if all the food and liquid that we eat is getting into the lungs, right? So the mechanism of airway closure is an important aspect of swallowing to prevent aspiration. Aspiration just means food and liquid is getting into the lungs. Our lab really is interested in all the different mechanisms of airway protection. So there's different ways that we can study this. We look at laryngeal closure during swallowing. So I'm going to play a video here. I want you to just pay attention to this area right here. You're going to see when the person swallows, that area is going to close off and it just blocks entrance for food and liquid to get into the trachea. Here, you can appreciate during these serial swallows, the larynx is elevating, the arytenoids are contacting the base of the epiglottis, and it's closing off the upper airway during each swallow. Not something you really think about unless you have a problem, right? I like this video here because it just really shows, when there's a deficit in that closure, you can see it was just paused here, but you have your vocal cords right here that are kind of that secondary line of defense. And if something gets into the upper airway, vocal cords are there to adduct and hopefully cough anything out that may penetrate the airway to prevent it from getting down into the lower lungs. So we have these multiple layers of protection, preventing aspiration, for ejecting aspiration. And this is a piece of swallowing, right? This is important. We just don't want patients to get pneumonia and respiratory infections because stuff went down wrong, right? We also look at how breathing is coordinated with swallowing to make sure that that synchrony between breathing and swallowing, closing the airway and breathing again, that mechanism, the timing of that is intact. So what does impaired airway protection look like? So this is, again, let's go back to what I said before, patients that have stroke, patients that have ALS. This is a profound impairment in airway protection. Okay, I'm going to play this one more time. Okay, so what I want you to watch, again, this area here, we don't want stuff in this area here. That's your trachea, okay? It's your upper airway. We want everything to go down into the esophagus. So in disorders where this is this whole mechanism is impaired, airway protection becomes really important. Because look at the severity of this. This is liquid. Most of it is entering down into the trachea and into the lungs. We don't want that. This is what I consider, when I see swallows like this, and I'm thinking of these disorders, all I can think of is the hangover, classic. Like this is classic dysphagia right here. These are patients we worry about for their nutrition. These are also the patients that complain. They're having trouble swallowing, right? Why do we care about this? Why do we care about airway protection? Because aspiration pneumonia carries enormous morbidity and mortality in patient populations. Data has shown that patients with confirmed aspiration on video fluoroscopy have an 11-fold increase in developing pneumonia. We know pneumonia is multifactorial. It's not just because of aspiration. But boy, if you're getting food and liquid bacteria from your oral cavity into your lungs, it doesn't take a rocket scientist to know that's a problem. There's also, other factors that this leads to. Patients that get recurrent pneumonias, they're at risk for reintubation. It increases healthcare costs, length of hospitalization, economic burden. It's a huge issue when patients are having these recurrent problems. But what about the patients that may be aspirating, but they don't know it? They don't feel it, they don't complain. The videos I showed you, those are pretty severe issues. But this is a spectrum, right? So what about patients that maybe aspirate, not every time they eat, but every once in a while? How do we detect these patients? I want you to watch one of these patients that I had. He has a cervical spinal cord injury. And in this video, this is kind of our fluoro x-ray setup in the lab. I want you to just watch him take a sip of some liquid here. And I want you to ask yourself, if this person came into your clinic, your primary care, and he came in with multiple pneumonias and you watched him eat and drink, would you say to yourself, oh, this person probably needs a swallow study, they might be aspirating? This is a guy that's taking a drink of liquid and going, well, I don't have problems. I'll do your research study, but I don't have any trouble swallowing. Otherwise healthy individual, young guy, very active. This is not somebody that we're going to take a look at swallowing. And it begs the question, should we, right? They're not complaining. He has these like recurrent pneumonias. So just to tell a kind of a quick story, when I first came to UF and I was a PhD student, I quickly realized that spinal cord injury and breathing research was kind of a big aspect of research here in the McKnight Brain Center. So I go to all these seminars as a PhD student, and every time I heard a talk on spinal cord injury related to breathing, I would see some version of this slide. Chronic spinal cord injury, respiratory complications are the most common cause of mortality after spinal cord injury. And everyone's talking about respiratory impairments, respiratory infections, so common after spinal cord injury. And as I started watching some of these talks, I thought, do they have swallowing problems? This is a lot of, pneumonia is really, really prevalent in this population. In fact, when I pulled up some of the literature and kind of dug into it a little bit, they specifically reported that respiratory tract infections, mainly pneumonia, accounted for 24% of all certified deaths and 58% for C1 to C4 injuries. This is in a very, very large N of patients with traumatic spinal cord injury. So as a swallowing researcher, I asked, well, do they have swallowing problems? And everybody said, no. They eat and drink just fine, right? They don't lose weight. They're on regular diets. No, I've never had a patient complain of any difficulty swallowing. Same with traumatic brain injury. If you look at the literature, a lot of patients at traumatic brain injury are at higher risk of developing pneumonia. And I just heard it over and over and over again. And it made me really wonder, well, what is going on? And this is where I come back to the rebranding issue. They don't have a swallowing problem. They eat and drink fine. But do they have an airway protection problem? They're different things, right? If we think of it as a swallowing problem, we're going to ignore it. If we think of it as a subtle deficit in airway protection, now that begs the question, oh, I don't know about that. Do they? When I looked into the literature, looking specifically at chronic spinal cord injury and chronic traumatic brain injury, nothing. Why? They don't complain. Why would there be? No one's really thinking of this, right? So it's interesting because if you look at the literature in acute spinal cord injury and acute traumatic brain injury, you see tons of publications. But this isn't surprising, right? So think about in an acute injury, no matter what it is, but spinal cord injury, brain injury, there's a lot of things that happen acutely that can cause dysphagia, right? So that if you look at the acute literature, it says like, 40% of patients with spinal cord injury have dysphagia, have swallowing problems. And when you look at it, you go, well, yeah, a lot of patients that get admitted to the ICU and have a breathing tube and are sedated and have reduced alertness and are on all these medications acutely, it's not surprising that they have swallowing problems. This is true for many populations that are in critical care. The question is, do these persist? Because if you look at the literature and you ask around, they say, but this is transient. They get better, right? So if we look at the time course of recovery, this is what happens. Let me paint a picture for you. So a patient gets admitted to the ICU or in acute care. They might get intubated. They're probably on mechanical ventilation. They're on all kinds of medication. They might not be alert. They're probably going to get maybe a PEG tube or at least an NG tube, so temporary nutrition. There's a lot of things going on. Swallowing isn't really a primary concern because we can get them supplemental nutrition until they kind of come out of it and wake up a little bit and get the breathing tube out and start to recover. As they move towards getting out of the acute care phase and moving towards, potentially moving to inpatient rehab, they're getting discharged, they're going to post-acute care. The things that happen in between, there's a lot that happens. They're weaning off the vent, they're getting back on an oral diet. And by the time they get ready for discharge, most patients are eating and drinking fine, don't have a swallowing problem, right? They're eating and drinking. But they've had all of these issues acutely, the intubation, sometimes they have laryngeal injuries from intubation. They maybe have had neck surgery if they needed an ACDF surgery. There's a lot of reasons that they would have dysphagia, but because they're eating and drinking fine, no one questions it. So they get discharged, they move out of inpatient rehab, maybe they go to outpatient rehab, maybe they go to home health, typically for cognitive therapy, physical therapy, occupational therapy, but not really for speech therapy to look at swallowing problems. So they kind of go off the radar. But what happens? A year after injury, pneumonia, 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 pneumonia. They're back in the hospital. They're getting treated with antibiotics. They have another pneumonia. It really makes me think about the streetlight effect, right? So I love this quote from this article that says, when they looked at incident studies of pneumonia in spinal cord injury, the underlying problem is paralysis of the respiratory muscles, which leads to poor mobilization of secretions, bacterial accumulation in the secretion, and resultant respiratory infections. While we're looking at the light and we're looking at, patients with spinal cord injury, and I'm just targeting this population specifically for get my point across. I think sometimes we look where the light is, right? And to take a step back, and my question was, maybe impairments, subtle impairments in laryngeal function or airway protection, maybe they are persisting beyond the acute phase and into the chronic phase. But are we asking the right questions? Not do they have a swallowing problem, they have an airway protection problem, and can we look at this? So I really wanted to study this, obviously, because I was dying to know, what does your swallowing look like? The thing that's so significant about this, and when I first explain this to people, sometimes they're like, okay, so what? So they have a little impairment in laryngeal function, it's probably minor, who cares? It's very, in the grand scheme of things, there are patients that have spinal cord injury, they have brain injuries, like, they're dealing with a lot of things, cognitive function, PT. But the thing is that even really subtle deficits in laryngeal closure during swallowing can lead to chronic episodes of aspiration. It may be a multifactorial reason that these patients keep getting pneumonia. And like I said before, for many of them, this is their primary cause of death. So we really hypothesized in our lab that this may be a very under-recognized yet profound complication in chronic SCI and perhaps traumatic brain injury that contributes to these high respiratory infection rates. So I wanted to study this, but I didn't have any money to do it. So I submitted a couple of grants to look at chronic SCI and chronic TBI. And I was so grateful to have funding from a grant from Brooks Rehabilitation, a collaborative research grant to look at spinal cord injury, and also Leo Brain Center to look at chronic traumatic brain injury and be able to kind of investigate what's happening here. And this was such a pivotal moment in my career because, you know, these internally funded small pilot grants literally have launched my whole career. I'm so grateful for this funding. This would have been really hard funding to pitch to NIH or larger grant mechanisms to kind of get these ideas off the ground because I had no pilot data. All I had was they have pneumonia a lot and we should probably care about that and look at it. So with this funding, we were able to look at spinal cord injury and traumatic brain injury. It's not usual that we put these two disorders together, very different disease mechanisms, but the central theme here is subtle deficits, right? And profound complication. So I want to show you just some data. I'm going to talk about the spinal cord injury data, and then we'll talk about the traumatic brain injury data and where we're at with that. So we got the spinal cord injury funding first. So we really kind of set off to look at these patients. We now have completed enrolling 20 individuals that have chronic cervical spinal cord injury between like a C1 to C7 with kind of varying levels of ASIA impairment scores from A to C. About 15 years post-injury, so they're, you know, definitely chronic individuals, around 43 years old, so relatively young, and with a baseline respiratory function that's about 67% of their predicted FVC. The point that I want to make about that is these are community dwelling active adults. These are patients that play wheelchair rugby, that are young, they're active, they're otherwise quite healthy, actually. No supplemental oxygen, breathing independently. I will tell you, every single patient that came into the lab was like, I don't have a swallowing problem, but I'll do your research study. And we're just really wonderful through the whole process because they kind of poked fun at me at first. They're like, cute, I don't have a swallowing problem, but I'll come and hang out. This would be great. We also compared them to 20 age and gender matched non-injured controls. So what did we do? So in my lab, we were really well equipped to study this because my expertise is in swallowing function. I use a method called video fluoroscopy. You've seen some of those images so far. And what that allows us to do is really look at nuanced changes in the mechanics of swallowing. We get real, I'm not going to go into this because this isn't a group full of swallowing nerds, but like we get real nerdy about the timing of the cartilages and how long does the airway stay closed and the durations and the reaction times and all sorts of stuff that we can look at in swallowing function. And what is so nice about that is that it allows us to really detect subtle changes in function and compare that to robust normative data that's out there. We kind of know what is normal for some of the swallowing muscles and the movement and the kinematics of these structures. So we can detect really subtle changes. We can also look at aspiration. So it's not just what's happening with the swallowing, but what's the consequence of that? Is stuff getting into the airway? And if it's not, is it almost getting into the airway? And are there patients that may be higher at risk? So I hate acronyms, but there's one I have to use. And we talk about LVC, and that's laryngeal vestibule closure. And that is really talking about that mechanism that closes off the airway. So I'll talk about LVC. Think of it as just airway closure, airway protection, laryngeal vestibule closure. If I say laryngeal vestibule closure too many times, I start to lose my tongue. So what did we see? So we took these patients. The first thing that we did is before even, of course, throwing any treatment at them, we want to know, do they have any problems? So we took them through a normal kind of standard research protocol for having them eat and drink different consistencies. We had them under x-ray, and the results we saw honestly shocked me because the patients that we had were young and so healthy. I was like, oh gosh, we're not going to see anything. We need older patients. We need patients that have comorbidities. But even in this younger, healthy group of patients, we saw a couple things. One, I want to talk about LVC integrity. So don't even think about timing. This is just how well does it close in the first place? Does it close all the way? And what lighting is not super great. Let's see if we can do this. The way we judge this, just kind of simple. We judge it as, complete, so that's normal. It closes all the way. There's no air space. Kind of a partial closure, meaning like maybe the arytenoids touch, but there's still a little space here. And then no closure, meaning that those arytenoids, that laryngeal cartilages, aren't even touching the base of the epiglottis, which is what's most important for that seal. So in this video, you'll see what does it look like when you don't get good closure. Okay. So here you can see this white space here. So this is someone at the height of the swallow that should be completely closed, and you can see that opening there. For the patients that do get good closure, we looked at the timing. So it's not just, does your airway close? It's how long does it close? Because you need it to be closed long enough for food and liquid to bypass the airway before it reopens. If your food and liquid is here and your airway is opening too soon, path-of-least resistance, right? It's going to go into the airway. We also care about, so that's our LVC duration. How long does it stay closed? We care about time to LVC. How quickly does it close? It can close for a long time, but if it's not getting there in time, it's not closing fast enough. And that's also an important metric that we look at. When we looked at spinal cord injury patients, and we looked at the duration of closure, and we looked at how quickly does it close, time to LVC, and we compared that to healthy controls, they were quite different. Spinal cord injury patients, they close their airway a little bit too short. They're opening kind of too soon. This red dot here is what we call a clinical impairment threshold. So when you take all of the normative data, researchers have kind of demarcated, like, what's the line where if it's below this, meaning too short, 400 milliseconds, we're getting into a red zone here. Doesn't mean that you're going to have a problem, it means you are at much higher risk for aspirating. When you look at the reaction time, same, this red line here, right? It's not closing fast enough, it's too long. This is what's normal. So this is really interesting, but the question is like, well, who cares? Like, what's the functional consequence of this, right? Like, it's a little too short, it's closing a little too long. Let's see here. So what does this look like? What's the functional consequence? You can see, this is one of the patients that we had. Remember the video I showed you where all of that liquid was dumping into the airway? That's profound. This is subtle. Let me play it one more time. You can see the liquid. This is the upper airway right here. A little bit kind of trickles in there. A lot of it comes back out, but you can see in the next slide, this is kind of a still shot. Here's that liquid getting in. Now a lot of it comes back out, but not all of it. So you get these little drops that kind of stay in the upper airway. Patients don't feel it. When we looked at all of these patients and we looked at, well, are they aspirating or not? We have a scale. It's called the penetration aspiration scale score. And what it does is it tells us if aspiration happens, how deep into the airway does it go? And what's the response to it? So if you look up here, we'll call it the safe zone. This is normal. Material doesn't enter the airway, right? Maybe it kind of flashes in a little bit. That happens to healthy people. We start to get in unsafe territory when we see things like some of the material is now touching the vocal cords and coming back. Maybe some of it's kind of staying and there's residue, some of it comes out. And then as we move down this scale, we see patients where aspiration is now lining the tracheal wall, it's, down below the vocal cords, and there's no response to that liquid in the airway. So what does this look like? So a patient takes a sip, get a little bit of, did you catch it? I saw the aspiration. Michaela did. Let's watch it over time. Whoops. Here we go. Watch right here. Wow, this screen is ginormous. You see that darkness right there?
Yeah.
It's a little bit of liquid lining that anterior tracheal wall. Remember this guy I showed you?
Are you cool with asking questions in the middle?
Please.
I'm so curious because I think a lot of us think of this as like a motor impairment, but to me, you just said a line. They've aspirated and they did nothing to cough it out or whatever. So there's a whole sensory component. here, too.
Absolutely, yeah, and where those intersect is really complicated to tease out, right? Like, you know, we have this whole, you know, in swallowing, this sensory motor integration that's constantly occurring. So to even say, well, of course they don't feel it, right? We can talk about the sensory component of that, but why it happens, that's hard to tease out. You know, pure motor, sensory, the sensory integration, where is it happening? Where's the breakdown occurring? That's a little bit harder to tease apart. So remember this guy I showed you before where I was like, this is a guy you would never send for a swallow study? That's his swallow. That's him drinking, looking at me going, you're crazy, I don't have a swallowing problem, but I like hanging out with you, and this research study is fine, and I get to see cool x-rays, and that's him aspirating. Absolutely no idea. Any questions so far?
Is this what you used from this morning?
No, that's coming. This is my TBI data. Yeah. We're a little bit further along in the spine cord injury data, but yeah, I'm going to talk about where we're going. I'm going to talk about what happens when we give intermittent hypoxia in a second. We're also looking at traumatic brain injury. We've enrolled 2 subjects so far. This study is not as far along because a little thing happened where I got a faculty appointment, left my postdoc, and everyone told me it's going to take a year to set up your lab. And I was like, how could it be so difficult? And a year later, we're finally up and running and seeing patients. So we're still actively enrolling patients that have mild or moderate traumatic brain injury. So far, we've seen 2 individuals that we've taken through a full protocol. These are patients that are 9 years post traumatic brain injury, 31 years old and 20 years old. These 2 individuals, again, these are patients that are working, they community dwelling, very active, again, independently breathing, similar type of story. This is just to show you a little bit of our, you know, inclusion criteria for these patients. So again, we're not seeing anyone that has a severe brain injury or that had a severe brain injury on admission. These are patients that, you know, for the mild category and moderate, you know, had minimal loss of consciousness. We look at their Glasgow Coma scale to make sure they're in that 9 to 15 range, that we're not enrolling anybody that has severe brain injury. I work with a tremendous group of neurologists. This is the benefit of being in the neurology department, who really are incredible about pouring through their medical records, looking at their MRIs, making sure that they don't have any sort of, you know, history of seizures or any brain bleeds or anything like that that would prevent them from participating in the study. This is the data I did in my garage in the parking lot before I came. So this is what's interesting about this patient population is they look a little different. So I talked a lot about airway protection, laryngeal vestibule closure with the spinal cord injury. Again, this is in an N of 2, so let's, you know, calm down about the results. But what I see as a deficit is their swallow reaction time. What does that mean? That means when you go to swallow something, you have to trigger the swallow to happen in a timely manner, right? So information, you're drinking something, I'm sure none of you have thought about this before, you got food and liquid, and then you make a decision volitionally to go, I'm going to swallow now, right? So you move the liquid to the back of your throat, and as soon as it crosses this threshold, kind of where your jawline is, ramus of your mandible, right at the base of your tongue, there's all these receptors that send information to your brainstem that say, let's go, close the airway, do something. And if that relay system is delayed, food and liquid is now starting to go through the upper airway, the swallow isn't triggered yet. So in these patients, again, there's that red line, there's that critical impairment threshold, your swallow's a little delayed. So it's not a lot. I've seen patients that have stroke that their swallow delay is like 25 seconds long. And you're like, come on, swallow. This is subtle. You really actually can't even appreciate it until you really slow down their swallowing, like frame by frame, and time out how long is it taking for this to occur. So a little bit of a different profile with these patients. So we have these subtle deficits, and the reason why I wanted to test intermittent hypoxia is because it's really straightforward. We don't have therapy for these patients. We don't have options. There's not an exercise you can do. There's not a rehab program that's established. I don't know what to do with these patients. Their deficits are subtle. It's a timing deficit. And we could throw the kitchen sink at these patients of like traditional swallowing exercises, but we don't have any data to show that any of it really is robust for, especially for subtle timing deficits like this. So I wanted to expose these patients to acute intermittent hypoxia because really from my postdoc experience looking at intermittent hypoxia to improve respiratory function in these patients, I was exposed to this. I had an understanding of what intermittent hypoxia does, and I thought, let's see what it does in the upper airway. Let's see if it changes things. I'm sure many of you have heard talks on intermittent hypoxia. I am not going to go into the depths of mechanism on this, but I will give you just if you've never heard of it, just a brief overview of what intermittent hypoxia is. So intermittent hypoxia is a strategy that we use to enhance serotonin-dependent plasticity. So what happens is, it's actually very simple. We give patients a mask, we expose them to low levels of inspired oxygen for 1 minute bouts. Low levels, I'm talking 9 to 10% FiO2. What is that? That's standing on the top of Mount Denali for 1 minute and then coming right back down to Earth. So we have a hypoxia machine, they breathe low oxygen, they take it off for a minute and a half, and we do this 15 times. The patients that are exposed to this treatment have no idea whether it's low oxygen, whether it's room air, they can't feel it. We've taken tons of data on this. It's 50-50 guess at best, whether or not they get it right or not. But what it does is it triggers the release of serotonin throughout the brain and the spinal cord. So using AIH is really just a means of increasing the amount of serotonin release throughout the whole body. And it triggers neuroplastic changes at the level of motor nerve cells that innervate the muscles. And this is what we've studied. It may have effects on other types of nerve cells. We don't know. But the beauty is this, it does this endogenously, right? So they're on the mask. We do this, it takes about 30 minutes. So just super briefly to kind of just walk through what is happening. Okay, you're giving them low oxygen. How is this going to improve swallowing function? So when the low oxygen is given, raphe neurons in your brainstem are triggered. You have a carotid body that senses low oxygen. It sends a signal to your brainstem to intermittently release serotonin at the level of the motor neuron. So serotonin binds to these receptors on the cell surface, and it triggers an intracellular cascade that leads to new synthesis of a pro-plasticity molecule, BDNF, probably heard of it. And it's high affinity receptor, TrkB, which is a BDNF receptor. And with some downstream signaling that if you have questions about this, you can ask Gordon Mitchell. He spent 30 years trying to decipher some of these pathways. But with some downstream signaling, what it does is it strengthens the glutamate synapse at the motor neuron to enhance synaptic plasticity. So you have greater strength, increased synaptic connectivity to ultimately increase motor output that lasts well beyond when the stimulus is given. So it's these intracellular cascades that are critical for creating permanent changes within these motor currents. So perhaps, because these deficits are so subtle, we can give them a little stimulant, a little boost. When we pair it with any sort of rehab or swallowing, can that get them over the edge? Give them just enough to get a little bit better. I have no idea, but that's the beauty of pilot data, is you just try it out. So what did we see? So we had all these patients. We wanted to put them through exposure to AIH. So briefly what we did something a little different with the SCI and the TBI. In SCI, we did their video fluoroscopy. We did the 20 patients and we said, let's only take the patients that have more profound deficits in airway protection. These are the patients that are aspirating. We wanted to expose them to intermittent hypoxia. 1 week daily sessions, we did it for 5 days. Intermittent hypoxia, day 1, day 2, day 3, day 4, day 5. Again, it takes like 30 minutes. We ran them and they either started out in an AIH condition or a sham condition. So they have the mask, same protocol, but they're just breathing room air and they don't know the difference. We didn't randomize into each group. Actually, each individual did both an AIH protocol and a sham protocol, so we could compare. So after they did the exposure to AIH, we did the fluoro again on the next day to see what changed, pre to post. We had a 3-week washout and then they flipped. They did AIH and they did sham next time, so we could compare within each individual pre and post AIH versus sham. It was a little different in the TBI group, and the reason why this is different is because we've learned a lot along the way about the effects of intermittent hypoxia. Here, we just did the intermittent hypoxia. We didn't pair it with anything. But in our brain injury population, we're pairing it with task-specific training. Because the data that we've seen so far is that AIH actually works best if you use it as a pre-treatment. So you give AIH, you wait 45 minutes, maybe an hour. You let protein synthesis occur, you let those intracellular mechanisms occur, and then boom, we do training. So in these patients, what we're doing for task-specific training is we're doing VLBC training. This is something that I developed in my in my pre-doc. So this is really cool to kind of see like all my worlds colliding to be able to train this mechanism. So what does that look like? How do you train that? So again, this is all work for my PhD. So look on the left here, normal swallowing. Again, I talked a lot about this mechanism. I want you to watch that mechanism close normally. This is just a normal swallow and it closes for about 500 milliseconds. Don't get distracted by the bottom. Look here.
Yeah.
Okay, here we go. Boop, swallow, close, open. Happens super fast. We go frame by frame and we can time this all out. But it just closes and opens, about a half a second. So for patients where this is too short, what we do is we train them to volitionally using biofeedback from the fluoro. We say, hold it longer in the middle of the swallow. Do something volitionally to exert control over a primarily brainstem mediated event. So normally it's just reflexive, right? You don't think about it. But we train them to close it longer. So this is what this looks like. So this is a person that we're asking to hold for about 6 seconds. Hold it, 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 breathe. So typically patients can hold it for about 6 seconds before they're like, I need to breathe. And we train that and they do it. We do it over and over and over and we pre-treat with intermittent hypoxia to see if we do this, will it translate to normal swallowing where their duration of closure is actually getting a bit longer. So just to kind of give you a sense of the timeline, just very generic. So a patient comes in, we do their fluoro. And then we, by the time, we do the fluoro, we take them over to the lab, it takes about 30 minutes. And then we'll start the intervention, either intermittent hypoxia or the sham. That takes about 35 minutes, mask on, mask off. I keep wanting to say wax on, wax off. I gotta get that out of my head. And then we wait, right? We wanna wait for those mechanisms to occur after the AIH. So we give them a break. We do all of our questionnaires. They go to the bathroom, they get a little snack, and we start setting up EMG. We use EMG as biofeedback for our training. I'm not gonna go into the details of that, because that will send me down the weeds. And then we do the VLBC training. It takes about 20 minutes. So this is what a typical training session would look like for them. So what does AIH do? So in our spinal cord injury patients, what happens is after AIH, the duration of laryngeal vestibular closure, this is without training. This was just the AIH. They get a little bit longer. And then compare. This is an insane screen. I just want to say that. When they do the sham condition, nothing changes. Same thing with the time to LVC, that reaction time gets a little faster. This is so subtle. I have to say, this is so subtle. This is not we're talking like 60 milliseconds sometimes. Like this is a small change, but the clinical impact of this is ginormous. And you can look at my bar graphs, and if I were you, I'd be like, yes, I want to see it, right? Like show me the swallow. Okay, well, because this is so cool. If you watch the baseline, this is the same person. Everything is the same. Bolus is the same, head position, everything we told them to do exactly the same. I'm going to show you the swallow at the same exact time and look at the difference between the two. And tell me what you see. Just tell me, you don't have to know anything about swallowing. What sticks out to you? I hope it's not too subtle that this is lost on everyone, because I look at these way too much. Okay, so. Oh, that didn't work, did it?
Here's some.
All right, I guess I can't play them at the same time. Let me try it. Okay, that was the same floor I showed you before, and then post. It's a little choppy, so it's hard to tell. Do you notice? No, it's so subtle. I look at these way too much. It's so, to me, even just as like a layman's eyes, it's so much faster. Watch. There's something so subtle about the timing of this. And what we see in the data is that it closes a little longer, it closes a little faster. It's so subtle. But for some of our patients, that is the difference between aspirating and not aspirating, which is really neat. When we looked at the TBI patients, again, subtle changes. Neither of these patients aspirated, so this is like pretty preliminary. I don't know what the functional consequence of this would be. There's the AIH paired with the training made their reaction time a little bit faster, a little bit, a couple of frames. But what that tells me is like, okay, this is stimulable. Like, what about patients that have a little more profound impairment that are aspirating? Can we put them over the edge? So we're still enrolling patients that have traumatic brain injury. So if you know anybody that has a mild traumatic brain injury, let me know. They don't have to have a self-reported swallowing problem. All the reasons I said before, they may not know, right? And maybe a subtle change in their laryngeal function because of the injury. So where are we going from here? I have so many questions. One thing that I am dying to figure out is what is it? What is it about the injury? Or is it something that's happening acutely that's making some of these subtle changes persist over time? So like when we talked about spinal cord injury, is it because they were intubated for 2 weeks, had a trach, they had some prevertebral swelling because they had a little neck surgery, they do an ACDF and get a little traction injury to the vagus nerve? Or did that truly resolve? And there's something about the spinal cord injury itself and the connection between the spine and the larynx and these C1 nerves or something that's going on that's causing these subtle deficits. We really want to understand this. What's cool is, jump ahead, is we can study this in a rodent. So there's a few of us out there that, you know, I said my expertise is in timing and these kinematics that are trained to do this in a rodent. So we can actually, with the right equipment, video fluoroscopy, to look at this in a rodent. And this is, we're submitting grants now to hopefully get this equipment to do things like a contusion injury, to do things like a C2 hemisection, to probe some of these injury mechanisms to understand we can control for the intubation, we can control for all those acute factors in a rodent. Let's figure out what's happening here. Are there ways we can prevent it? Are there risk factors? Are there things we can do earlier to better intervene and maybe prevent some of the pneumonia that's happening? TBI is an interesting one. I get this a lot, like, even a mild TBI, like a concussion, like, why do they have swallowing problems? Again, they don't swallow, they eat and drink, right? But what is it about swallowing? So I just want to review a complex system because I think that this will make you go, oh, I could see why they could have issues here. So when we think about swallowing, we have the tongue. You eat or drink something, you have all these sensory receptors, and it's, when you have something in your mouth, it's sending information to your brain about the texture, the volume, the size, because whatever's in your mouth, you swallow differently, right? You have take a huge sip of something or a small sip of something, your pharynx and your throat accommodates to the properties of that bolus. So it sends information to the brainstem to say something's coming down the pipe, and this is what it looks like. We got a 20 ml bolus coming in hot. It's, you know, sour, it's whatever. And it's going to send that information to the primary sensory areas where you process things like general sensory information. touch, pain, temperature. It takes the information that the brainstem has told it about those crude areas, but then it sends it to association areas in the brain, right? Integrates information about general sensation, proprioception. What do we do about this? Like, how are we managing this bolus? Sends that information to these frontal association areas to integrate a motor plan. Sends that information to premotor areas to decide what muscles to use, how to use them, what's the intensity. And finally, to the motor execution area in the primary motor cortex to send down that final command to know exactly how to manage that specific bolus. So we think of swallowing as brainstem, brainstem, brainstem. There's a lot of cortical influence that's telling us how to swallow, the context. Are you distracted? There's so many cortical aspects of swallowing. We kind of take for granted, we don't really think about or we don't test very much, but it makes you appreciate somebody that's had a brain injury and there's disruption to any of these processes, you can have subtle changes. So that's where we're at. We are writing grants like our house is on fire to study this more and to really get into the complexities of the mechanism. We want to study this in more patients. We want to have a diverse population. We want to understand who are the patients that are having the most problems. Does it get worse with aging? Does it get worse when you have comorbidities? Does it get worse when you have pneumonia? Is this a vicious cycle? You have subtle deficits, then you get pneumonia and you get sick. Oh, now your swallowing's worse. And now you're aspirating more. Now you're getting pneumonia. And then it's hard to get out of that vicious cycle, which is what we hypothesize. So we want to understand that. Huge thanks to my research lab who has been diving into this like so hard, getting our lab up and running, getting our fluoro. I have an awesome team. I'm so grateful for them. I'm also grateful, especially for the funding to be able to carry this work. It truly has created a whole programmatic line of research for me that I'm so excited to test more. To Emily Fox, to Gordon Mitchell, my postdoc mentors who really helped encourage me to submit these grants as a postdoc, to get my independent line of research up off the ground, and the crew at Brooks Rehabilitation. All of our spinal cord injury patients we saw at Brooks, they have a tremendous team there, and I'm really, really grateful for the coordinated care and helping us recruit these patients, and it's just been awesome. So with that, I will take any questions. Any of these data. Yeah.
So, thank you so much. This has been I learned a lot today. Thank you very much. So in my field of Alzheimer's and what I know, a lot of folks have said, hey, you know, most of our patients have Alzheimer's, but really what are they dying of? We've talked about this a lot with Gordon.
Yeah.
A lot of them end up in a home with pneumonia, right? Do you something about this? People say, well, you know, they forget how to swallow. That's literally what I've heard people say.
Yeah.
Do you think there's some relationship?
For sure.
Chronic?
Yeah, Alzheimer's is hard because when you get into patients, not just Alzheimer's, but any sort of cognitive decline, dementia, other flavors, and if you work with, you see these patients, there's a difference between a really predominant cognitive deficit where they're putting food in their mouth and they don't even that happens. You know, we've had patients who you give them mashed potatoes and it's like there's such a dissociation, they're not even sure to swallow, right? There's a lot of mechanisms in that pathway of, you know, what you see, all those mechanisms in the delay is going to be, you know, really predominant. That delay, that response time, with all treatment, right? Aspect that it's you have to look at it kind of differently than just someone else subtle. You know, they're waiting for subtle changes. But these patients often, when they move through that cognitive trajectory, they get more severe swallowing gets severe, but is it swallowing or is it the cognitive component of swallowing, right?
But it's less conspicuous, like just aging,
Yeah,
because that happens too, right?
yeah, that happens too. And there's some work looking at in aging, we see a very similar profile to the spinal cord injury. Things like delayed timing of the window closure, delayed swallow reaction time that gets, so the normative data that I talked about, it shifts in aging, right? So swallow reaction time gets a little longer as we age. Now, for some people, not a big deal. They don't get pneumonia, they're healthy. But for some people that may have comorbidities, maybe they're transiently aspirating and they're getting pneumonia. And again, it goes back to the original thing. They're not complaining about eating or drinking, right? So how do we know? And there's becoming more of an awareness about, they actually call it presbyphagia, the age-related decline in swallowing, right? So there's more of an awareness of it. Not that anyone's really doing anything about it. And it's hard in our medical model. How do you treat that, right? They don't have a disease. They don't have, you know, even when we do fluoro, sometimes they're not always aspirating. So sometimes even if you do imaging, you might not catch that there's a functional consequence. You're sitting them up in a chair and you're like, okay, take a sip of something. And they're like really alert and they're like looking around the machines. They swallow differently then, right? But now get this person out, you know, out to dinner, it's loud, you know, things are flowing. Distracting your tongue, you know, are patients falling off, right? They're being challenged in a way that it's hard to do experimentally. What's interesting about the spinal cord patients to that note is when I started seeing them, I was doing this really strict, very, you know, well-documented research protocol. It's very strict. And one of my patients goes, because we don't fall like this. And I was like, what do you mean? He goes, oh, wow. Someone's holding a cup for me. My head is going back. I'm trying to take as much as I can. He's swallowing. He's like, all right, hold me the cup. And he's like, swallowing. He's like, this one's swallowing. Or that straw. And hold the cup for me for taking small sips. So I'm doing it as fast as I can. I'm trying to be efficient. I was like, do that. Boom, aspirated. And I was, hey, we have to accommodate to what our patients are actually doing, right? So I think a lot of these deficits, they're just not being recognized for all the reasons I talked about. But it's interesting because maybe if we look at these patients that are at higher risk and we recognize it, it's almost like a biomarker, right? So maybe they're not aspirating, but we see, oh, your timing is off. You may not be aspirating. Things are changing. It's just subclinical. We're not seeing, you're not getting pneumonia, but something's happening. So these are all things that we have sit in. It's like, what about these populations? Not from ALS. I do study these populations because they do really need our help. I'm really interested in these patients that I think we're missing. Not to say that every injury patient needs to enroll in speech therapy and go through, line out the door to get swallow treatment, but we need to be aware of it and perhaps diagnose it earlier. And there's things that we can do about it to prevent it. Yeah.
Okay, so Stacy White is wondering if you have any information regarding the length of time that results may last post-treatment?
Yeah.
And does anything suggest that results may be limited with return to pre-treatment level of dysfunction after a certain period of time?
Yeah, so we actually have a grant in right now that is directly asking the question of duration of effects. So in this pilot study, we looked at the day after because we really wanted to know, like, does it work at all? Like, is there any sort of, do the effects last after one day? But we have a grant in with the Craig Nielsen Foundation that we're actually going to test, do fluoros a week later, perhaps a month later, to understand what's the dosing here. We also only gave them intermittent hypoxia for 5 days. Do we need to increase the length of that training? Trying to tease those things out. And this is something that Gordon's group in their basic science lab, they're also tackling. There's a lot of groups who study intermittent hypoxia that are asking the same question. So we have data that it improves walking function, that it improves hand function. So we're able to, you know, we're seeing these results, but it doesn't really matter if we can't get the results to last, right? But the mechanism of AIH suggests that perhaps it can because of the plasticity that's occurring, and that's the goal. What that dose looks like, we're still kind of teasing it out and trying to figure out, but that's absolutely the goal. Yeah.
Okay, just real quick.
Rock, paper, scissors, I don't know.
Just a couple questions. One, just anecdotally, what was the individual's post-spinal cord? Like, were you like, you owe me a beer? I mean, how did that work out when they said, told you so? So just kind of curious what that little reaction was.
Well, so it actually opened up a good conversation because, you know, we kind of worked with the IRB to be like, what do we do about disclosing this information
Mhm,
to these
yeah.
participants? You know, do we refer them for therapy? Like, what do we do?
Yeah,
Because this is kind of, we weren't really expecting it. They were shocked, right? When we said like, yeah, and not to sound alarm bells, like we all aspirate, right? A drop of liquid in the trachea isn't going to send someone to the hospital. It's the recurrent nature of it, right? It's the, you know, over time, you become desensitized to it, accumulates. We know that in spinal cord injury, there's some really neat data at Ohio State, gosh, I don't remember the researcher's name, that suggests that patients with a spinal cord injury, the injury itself makes you more susceptible to the effects of pneumonia. So there are patients that are at higher risk, the effects of pneumonia more than, you know, a healthy individual. They just couldn't believe it because they're like, what are you talking about? I don't feel that. But they also have very weak cough function, right? So then it is the question of, you know, is it that they can't eject it because of their cough function? Is it because they really don't sense it? Are they desensitized to it? There's a lot to tease out there. Luckily, I know a pretty good cough researcher in the back that is helping me understand, you know, their cough response. What is their, you know, how does this contribute to the overall picture? We're just about to start a study. We're going to do laryngoscopy and look at the vocal cord function of these patients, because again, streetlight effect, right? Oh, we cough, intercostals, weak respiratory muscles. What about their vocal cords? If there's damage to the vocal cords and they're not getting subglottic pressure, it's really hard to cough. Your vocal cords can't come together, right? So is that a contributing factor to their poor cough function? Again, it all comes back to the streetlight effect. Are there other things happening that we're just not looking at or considering? So Michaela and I are about to publish a paper on this and looking at cough function, and then we're going to be scoping all these patients that we saw to look at their vocal cord function. See what's happening with the whole larynx in these patients.
And then just second, real quick, if I could, I know it's after 4. So I think I want to make sure I understand this. You had the patient's post-spinal cord. I think it was the LVC, you know, X number where I think it said had complete closure, X number. I mean, I know it was a small N, but I'm sure you're curious, is there any differences that were obvious between, I mean, in terms of who knows?
The one that didn't get complete closure?
Yeah.
Not really, and honestly, a part of it is because we don't really have methods to test that type of subtle difference. So if somebody, right, is here when they're closing, and then they go to here, it's still incomplete, but there's been a difference there.
Mhm.
The way that we can actually look at this, you know, timing is easy. We can do subtle millisecond changes, right? But that amount of closure, there's a method that we use. It's a computational analysis of swallowing mechanics. It's called CADLM. And we actually look at the relationship of all the structures. So is something compensating for something else? What's the relationship? The problem is God, it's so time intensive to do that analysis. You're doing coordinate tracking. So I actually was just at an AI conference that I came from this morning to meet with some collaborators to be like, we have this MATLAB program. It's semi-automated. It hasn't been updated in a billion years. Is there anybody that can help us automate this and use coordinate tracking, line detection software, you know, MATLAB things that I don't know about? Can we make this better and make it automated so we can do that type of analysis faster? Because no one's using it. It's way too time intensive. So I'd love to be able to collaborate with some machine learning AI folks to figure out if we can get at that a little bit better.
Thank you.
Barbara Smith had a question as well, but I think you might have addressed this. She had asked, she said exciting data. What are the relationships between the observed changes in LVC timing following TBI with airway clearance / cough course and coordination?
So in the TBI, I hope I'm answering this question. In the TBI, we didn't really see any changes in the laryngeal closure. It was more of that swallow reaction time. But that was, 2 people. So I'll be interested to see how that story changes as we enroll more patients and maybe the different patients have different etiologies. I don't know. I would be shocked if it wasn't a little more diverse. And I think what she's asking with the TBI patients, they don't have cough impairments the way that the spinal cord injury patients did. So I'll be very curious if we do get some patients that aspirate, what the response is going to be to that. And maybe we won't get any patients that aspirate. I don't know. We'll have to see what our demographics look like. Yeah.
I'm curious, in your SCI group, did you see anyone not respond to AIH or did they all show some improvement?
So we only looked at 5. We did do 6. I haven't analyzed that data yet. They all responded to AIH, but with different degrees of magnitude. So, but there wasn't, 3 people responded robustly, and some people didn't. Everyone improved. Just to say anecdotally, everyone improved a little bit. But again, they don't have profound deficits, so the window of improvement is only so much, right? Like their duration of LVC isn't going to be like, whoa, they closed for 6 seconds. Like that would be insane. Just a normal swallow that you're like, oh my gosh, my airway's closed too long. Like that wouldn't happen. So the window is so small that it's actually hard to get at magnitude, right? Because there's only so much room to change when the deficits are mild. Now I hope in our future work we get a little more heterogeneity in the severity as we get older participants, as we get more severe injuries, to kind of tease out responders and non-responders. And that is something that I want to look at. I think it was a kind of a fluke that all of them, I think with a larger sample, we're going to get more of that variation of responders, non-responders. But to answer the question you may be thinking of, yes, we're going to do genetic and take saliva samples. We're going to look at inflammatory markers. We're going to take blood to look at, we're also studying this in stroke as well, to look at who does respond and who doesn't respond most to intermittent hypoxia and teasing that story out as well. So Maria is going to be a fantastic collaborator for us to help us tease out those biomarkers that predict those responses.
Thanks.
This is amazing. I wish we had more time to ask other questions. Thank you very much for.